Hello, everyone, and welcome, and thank you for joining us today for today's webinar on research on the integration of behavioral health in primary care. Before we begin, I'd like to go over a few quick details in regards to WebEx logistics. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is on the right-hand side of your screen. You may have to click the arrow next to it to expand this section. We will be answering questions at the end of today's presentation. In addition, we also have live captioning today. It should be visible on the side of your screen, but you can minimize it if you would prefer not to see it. And I'm going to go ahead and pass things over to Matthew Simpson to get us started.
Hello and welcome, everyone. Thanks for joining us today. My name is Matt Simpson, and I am a family physician within the Division of Practice Improvement in the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, or AHRQ for short. I work closely alongside Amy Eden, who is our acting director for the National Center for Excellence in Primary Care Research, which we'll often call NICE-PCR for short. On the next slide, we can see the text from AHRQ's authorization in 1999 that describes what a Center for Primary Care Research should do. A fun fact is that AHRQ is the only federal agency that has a specific congressional mandate to conduct primary care research. NICE-PCR is the center within AHRQ that coordinates and leads all the primary care research initiatives across AHRQ. On the next slide, you'll see a great diagram that shows a lot of the activities and purposes for the National Center for Excellence in Primary Care Research. We do a lot of things. One of those things is try to communicate important primary care research findings, which is the purpose of this webinar. Next slide. As we transition to the purpose for the specific webinar today, I just want to highlight that behavioral health and substance use disorders has been a prominent focus within the work of NICE-PCR, and it's included on our website under research initiatives. As you'll learn this webinar, and probably already know, the main reason behind that is the key role that primary care plays in addressing behavioral health and substance use disorders. All right, and this segues nicely into the next slide, which is the focus for today's webinar, which is research on the integration of behavioral health and primary care. A couple of things to note. Today's webinar and slides will be made available later on the AHRQ website. The links have been put in the chat. The other thing to know is that previous webinars in this series are available on the AHRQ website. And if you stay tuned to AHRQ channels, you can see announcements for future webinars on this topic. All right, next slide. This is what we're hoping to accomplish today. We're going to have two interesting studies that will be presenting work related to behavioral health integration in primary care, and then a third presentation that's going to highlight AHRQ's Academy for integrating behavioral health in primary care. And with that, I'm going to pass it over to our moderator for this session, Garrett Moran. Dr. Garrett Moran is the principal investigator for AHRQ's Academy. He has extensive experience in behavioral health integration and will facilitate the Q&A and discussion that comes at the end of the webinar today. Welcome, Garrett.
Thank you, Matt, and welcome everybody. I'm very glad that we have such a good audience to hear today's discussion. I think you're going to hear some very interesting presentations. We have 4 primary care researchers here today. Counting me as one. Actually, Matt's another. First 2 will discuss their research on the integration of behavioral health in primary care. Join me in welcoming Andrea Graham from Northwestern University's Feinberg School of Medicine. Andrea will present on her research study on implementation of digital mental health tools in ambulatory care coordination. Her presentation will be followed by one from Natalie Moisey. Dr. Moisey is from Columbia University's Irving Medical Center, and she will be presenting on her research study, Transform DEP Care, a theoretical approach to improving patient engagement and shared decision-making for minorities in collaborative care for depression. Dr. Neil Corson and I will lead up the third presentation. Dr. Corson's from the Maine Health Institute for Research, and together we'll be talking about the ARC Academy. Be sure to save your questions. As has been mentioned already, we will have a question and answer session at the end, and you can pop your questions into the chat throughout the webinar for later discussion. Now I'd like to welcome our first presenter, Dr. Andrea Graham, on her study Implementation of Digital Mental Health Tools in Ambulatory Care Coordination. Welcome, Dr. Graham.
Thank you so much, and to ARC, and for both the funding, of course, and for this opportunity to present. I'm just really appreciative of this opportunity to showcase our work in this area. So next slide. So what I'm going to spend time on is talking about the role of digital mental health interventions being implemented in care coordination. And care coordination services have been developed to provide safer and more effective care for people who have trouble managing managing their typical health care. So these are individuals who have been referred specifically by their doctor into I think by mainly the doctors, but it could also be through their health plan, into this specialty service. And a large portion of patients in care coordination actually have mental health conditions, but traditionally care coordination focuses primarily on physical health problems. And so the role of that care coordinator is to take a holistic view of patients' health, and we want to then improve the health system efficiency, but there's still some gaps in doing this. So next slide. And so one of the solutions is to then think about the role of digital tools. I'm co-director of the Center for Behavioral Intervention Technologies at Northwestern University, and we think a lot about how do we implement and optimize digital mental health tools for various settings, including healthcare settings. So I then strongly believe in the role of digital mental health interventions, which can provide patient-facing apps that promote self-management strategies for common mental health problems such as depression or anxiety. And they're effective when they're typically more effective when there's a coach involved in addition to just simply providing the app. So typically what we call coach-guided interventions are better than self-guided interventions. So therefore, a digital mental health intervention for depression could improve access to, reach for depression services within ambulatory care coordination and improving coordination of mental health services. Next slide. The intervention that we're studying in our trial, I want to be clear, you could sub in any intervention. And I'm going to talk more about this later, which is our goal is really focusing on the implementation process of a product, not necessarily the product itself, but and I use the word product because in a conversation with compliance yesterday, that's the word that they wanted to use, and it was very helpful as a differentiator. But the intervention that we're focusing on is IntelliCare Plus. So this is a guided, so with coaching, digital mental health intervention for depression and anxiety. It's demonstrated effectiveness among primary care patients previously with high and sustained engagement. That's a big win for our field because typically digital mental health interventions have not been engaging. We call it a hockey stick problem. People come on and then they use it for about a session or two and then they leave. We were able to demonstrate over several trials high sustained engagement with this tool. And now it's being moved towards commercialization through SBIR awards and otherwise being hosted by a company called Adaptive Health. Next slide. And this is an example from the trial with primary care patients where we demonstrated the effectiveness of this intervention, where effect sizes were consistent with what we might see for face-to-face psychotherapy, which was very encouraging and exciting in terms of the benefits of this tool as relevant for then implementation in diverse settings. Next slide. So the aims of this research project is to adapt then the digital mental health intervention, in this case IntelliCare Plus, to address implementation barriers specifically within care coordination, and to think about and actually optimize, and I'm going to come back to this word, a multi-component implementation strategy. Implementation strategies are put simply by Greg Curran, which was amazing for the field of implementation science. It's the stuff that we do to get people to do the things that work. So it's really thinking about what is the stuff that we need to help care coordination really roll this out in their service. And the AIM-3 as originally proposed was to conduct a randomized rollout effectiveness implementation study of the IntelliCare Plus platform where we would optimize over time and do a sustainment period within the 4 regional teams of the Ambulatory Care Coordination Service here at Northwestern Medicine. Our primary outcome for the whole trial is our primary implementation outcome is reach. So can we improve the number of people who get access to depression services, specifically through a digital tool, relative to the denominator being the proportion who would be eligible? And our primary effectiveness outcome is then making sure is looking at changes in depression severity, because anytime you roll it out in a new population or setting, you always want to make sure that you're seeing where you may or may not be sustaining the outcomes of previously shown. Next slide. And what we're doing is we're applying a solution-focused research framework known as the Accelerated Creation to Sustainment Model, or ACTS. And what I really want to point out to this slide, you can direct to some of the references on the bottom in terms of reading more about this framework. But this framework inherently, which is what I really love about it, it was developed through our center, and it's inherently based on the role of iteration over time. So when we roll out technology, or when we roll out anything, rarely works as expected, and we're going to come back to this point, foreshadowing, and we need to embrace the fact that things change. We also, with technology in particular, like in and of itself, if you have a 5-year trial, like think about what Facebook looked like 5 years ago. Like technology moves fast, so we have to actually, so that we don't end a trial with obsolete technology, we have to be thinking about how that can change while sticking to the parameters of what we set out to do in the first place. So next slide. Okay, so here's the methods that we had planned to do. What we wanted to do from a technology perspective is really to expand the patient management tools that are available within the IntelliCare Plus platform to include things like medication adherence, decision support, and other media. And we wanted to integrate the IntelliCare dashboard for care management into the ambulatory care coordination's electronic health record. We also wanted to then train and supervise care coordinators in actually delivering IntelliCare Plus, meaning that they would be the ones that would be referring patients and providing that coaching service, with our goal of being, as a researcher, is monitoring and providing supports to make sure that they're then delivering coaching to fidelity. And overall, to implement this sequentially across the 4 regions using a stepped wedge design, and that we would be referring patients with PHQ-9s greater than or equal to 10. So that's a common self-report depression screener used in clinical practice, and a score above 10 indicates clinically significant depression symptoms. Next slide. All right, so going back to the notion of implementation strategies, as I mentioned, technology rarely rolls out as planned. And so what we did was we conducted a field test. And a field test is a word that we often use in our center, more thinking about technology, but it really captures what is the implementation strategy known as conducting a small test of change. Here, we are calling this a field test, where you're looking to see how does it work to help inform broader rollout. While yes, on the call, you're probably thinking, isn't that just a pilot? Absolutely, but it's really it's not to sort of be sequential and developing, preliminary data. It's to really sort of do a dress rehearsal is how I love to think about it. It's really the dress rehearsal to the big performance. So what we did is we worked with we trained and supervised 4 care managers who were purposely selected as internal champions for this work. They weren't familiar with IntelliCare before, but they were excited about being engaged. And one of the key things when you're thinking about implementation is sometimes it's useful to partner first with people who might be really high, readiness to do this, and then learning more about barriers to roll out over time. And the goal was that they would each enroll 5 patients each, so that we would see 20 patients total. Next slide. All right, so what we found was 3 out of the 4 care coordinators, so 75% of just these 4, enrolled a total of 8 patients altogether. So 40% of our targeted 20. Next slide. What happened, right? So rather than, I think what made this so beautiful was we then have this opportunity to delve in and really say, let's now think about all levels of which that we're trying to optimize, and what do we then need to do for our trial. So next slide. First, we looked at effectiveness. So we were seeing that actually on the whole, people were improving. It's a very small sample, obviously, but this was really useful to see that, like, okay, actually those who came in doing okay. Excellent. Next slide. We talked extensively with the care coordinators during and following the rollout to get their feedback. So one of the methodologies that we largely embrace in our center, and particularly also in this trial, is human-centered design, where we're actively engaging with the people, both at the systems level and at the intervention use level. So we think of both the care coordinators are using the intervention and patients are using the intervention. And we try to understand like what were pros and cons of how this rolls out in doing this. And they felt in these quotes really positive about the role of this app for their patients and the role of having a digital depression service. And they also saw they thought about sort of who is the right patient profile. So once they got people in, they were really seeing the value of delivering this with their patients. Next slide. But we learned a lot. And so as I just mentioned, the strengths were that the care coordinators did like the tool and that patients on average improved, but there was a lot of areas that require optimization. So one, and this is one of my sort of key soapboxes of being someone who does implementation science and service design, is that it is very challenging to fit, we're learning that it is more and more challenging to fit digital tools that use asynchronous communication coaching into workflows that actually utilize telephone synchronous phone calls. So meaning it was very hard for care coordinators to be both a coach, which was primarily via text message that happens multiple times a week with a user of the app, to then also be their care coordinator role, which is their primary responsibility, of course, which is monthly phone calls. Those workflows didn't align. And what we realized is that we needed to disentangle some of that. We also learned that implementation really needs to focus on, we need some strategies around how do we identify and refer patients to uptake into that. So what strategies do we need to make sure that the care coordinators are equipped to appropriately identify the right patients, because 40% out of 20 among a really engaged group of care coordinators, we want it to be higher in the trial. And then the other systems level change that we needed to optimize was that over the course of COVID, the ambulatory care service was redesigned to actually, they no longer do regional care delivery. So there's no longer regions. The care coordinators work across the regions. So implementation, separate from even digital and technology, implementation the settings can change, the systems can change, and we need to be able to adapt to that. And this is, again, why utilizing frameworks that embrace iteration, it can be really important to this research and really these, real world scenarios, of course. Next slide. So here's where we're going. We are launching the new trial later this month. So I'm feeling very excited, but we've done a lot of really thoughtful, I believe, changes to really think about how to optimize this ultimate goal. I'll come back to aim one of improving the reach of depression services, right? That's our main goal. So now we're going to do a system-wide deployment using what's called an interrupted time series trial design. So instead of that stepped wedge where we roll it out over time, where the first 3 to 6 months is going to be a control phase where we are going to do an initial presentation to the care coordinators. We're going to indicate that this program is available. They can do what they want. And as researchers, we will be hands off. So that's a typical deployment of any other kind of resource. And we're trying to match that here, where you often get, hey, this is available to you now as a clinician. Great. And we'll see you soon. Once that happens, we've established a baseline of what our rate of referral might look like, our reach rate. And so then we're going to monitor very systematically and deploy data-driven, collaboratively determined implementation strategies quite systematically. So we often would want to do it at will, but because this is an important clinical trial and research study, we're going to do it in very systematic ways so that we can track when we added this, these were the then changes in the reach rates we saw. We're then going to, once we do that for several months, we're going to move to a sustainment phase because we still want to see what happens when we remove research team involvement, and we're going to monitor that. So we won't have randomization anymore. This will be available across the service, but this new time series design enables us to be able to still measure change. Next slide. we are also disentangling the service. So how this digital mental health intervention is being delivered. So originally, as I mentioned, the care coordinators were going to deliver coaching. We're now going to actually have the company that hosts the tool be the ones delivering coaching. That's actually consistent with their business model that normally they would provide coaching as part of their service offering. It's actually very consistent with where the digital mental health field is. So when we did market surveillance, that's very consistent with a lot of companies are doing coaching in-house. It is not, it is more and more through implementation studies like ours, we're learning that coaching in clinical settings can be really hard. So that's why a lot of companies are moving that in-house. So this really does align with their standard business model as well, which is good for sustainment. And then last slide, this is my favorite part. I must say is that our whole goal, our whole sort of swim lanes is to really think about lowering barriers to patient enrollment and getting them in, and like thinking about barriers across different levels. So one idea is that we've lowered the PHQ scores so that we can have more people accessing services, which will be more people accessing services. We are working to embed a patient portal into the electronic health record, and then we're really thinking about ways to standardize, and we've actually built like a strategy playbook that we're hoping to develop and iterate over time that can then become a disseminable output and product from this trial, where we're standardizing our targets across our implementation strategies. We're then creating really structured implementation strategies, as I've mentioned, and then we're going to be subsequently rolling them out over time. I look forward to questions. Stay tuned for where this will go, but we're really grateful to ARC for the opportunity to study this. And I'll just mention that sort of working in healthcare, it's important and fascinating, and it's where we need to be going. And these barriers are not, some of the snags we've learned along the way are not, I think, unique. And so it's great that we're having this chance to more systematically study how to overcome them. So thank you.
Thank you, Dr. Graham. Very interesting, and I'm all excited for the sequel. Really be interested to see how your research comes out, and look forward to your next presentation. And next, we have a presentation from Dr. Natalie Moisey, who's presenting on her study on Transform Depth Care, a theoretical approach to improving patient engagement and shared decision-making for minorities in collaborative depression care. Take it away, Dr. Moisey.
Great. Thank you so much for, again, also for this great opportunity to present and for the funding. Next slide. Okay, so there have been many efforts over the last decade to implement collaborative care. As many of you know, collaborative care models involve population level depression screening, referral to a care manager, often a social worker, who provides treat to target therapy and care coordination under the supervision of a psychiatrist, and with close collaboration with primary care doctors who are often tasked with titrating antidepressants. And so in one of the largest government-led initiatives in historically marginalized populations has been the New York State Office of Mental Health's Collaborative Care Medicaid program. This is led by Amy Jones currently. And so in 2012, the state provided training and centralized the AIM Center that many of you may know. They also provided funding and quality monitoring. And early implementation outcomes showed that they actually saw improvements similar to the original clinical trials amongst these 32 early adopters. In 2015, they then scaled up to about 611 clinics. And in addition to the prior implementation strategies, they also provided a reimbursement code. A lot of what we're talking about is how do you sustain, how do you keep things going? You need to be able to pay for these interventions and bill for them. So through Medicaid, these clinics were provided a code where they would be given $150 per patient, 75% for enrolling a patient, an additional 25% for showing improvement. So 611 clinics got at least one session of technical assistance, and to date, about 300 clinics are at least providing the quality monitoring and the data back to the state. And what they've found so far is that those clinics that can do all of it, attend the technical assistance, bill for enrollment, and bill for that retainage extra fee, are the ones who do better in general in terms of the collaborative care outcomes. In 2016, I joined, and as an OMH policy scholar, and my job and my tasks were to assess and help with some of the cost effectiveness analyses. Unfortunately, it was cost neutral. Maybe that's a good thing from the state's perspective. And then to look at some barriers to sustaining these models and start developing strategies and sustainability methods before testing a sustainability strategy around 2020 to 2022. Next slide. So the first thing we found in our study was that these clinics, that what you can see here is that those barriers like funding and I don't know what collaborative care is, I don't have the training, I need help with IT, those were less often cited as barriers. And that gives you a sense for the mechanisms by which maybe that technical assistance and funding was working in terms of those implementation strategies. I know there's a lot of interest in our field of understanding, how do our strategies work? Why do they work? Where do they work? Next slide. We found that those sustaining clinics had barriers, though. So most clinics are able to sustain these models. This is about 4 to 6 years after those early adopters started implementing collaborative care. And some of our qualitative data shows that they can, you have overburdened PCPs with competing priorities. It's harder to engage the more complex patients in the sustainability phase. Care managers also have a lot of barriers. There's this perception of insufficient resources. You have these complex workflows. We actually saw this decay in the quality of screening over time, right? And so initially you could trust your PHQs, but medical assistants are quickly just putting in a 0 and saying, oh, you're not depressed, right? Just to check off the quality metric as you enter that sustainability phase. And what we found was that caseloads for these care managers went from about 137 patients per care manager FTE to about 37 in these sustaining clinics. And what you see also is this kind of decay in reach and improvement in fidelity in these early adopters who otherwise did great when they first implemented collaborative care. And we start thinking about, what do we need to actually sustain these models? How do we adapt to changing workflows? Next slide. So our aims were to refine a strategy for sustainability originally centered around electronic shared decision-making prototype, and then assess impact on provider and patient optimization behaviors. We chose treatment optimization, or reach of any treatment, not just collaborative care, but also aimed to assess collaborative care reach, which was tied to reimbursement and thus sustainability. Next slide. In terms of our methods, these are some of the methods that emerged out of these grants of starting to think about, what do we need to sustain anything in terms of any intervention? And we leveraged something called the dynamic sustainability framework that many of you might know. And that posits that you can't just keep delivering collaborative care the way you envisioned it. Sustainability requires iterative improvement and adaptation and ongoing learning. And we paired this with something called the behavior change wheel, which calls for targeting the barriers of behaviors at the care manager level, at the provider level, which involves referral, at the patient level, which requires ongoing, adherence to their medications as well. And then we leverage some user-centered design similarly to operationalize our findings. Next slide. Sorry, it's so noisy. It's New York City. Okay, so this is our stakeholder engagement. So we actually hired someone we used all of our mixed methods that I talked about and map these to behavior change techniques. And we hired someone from industry. And I love what they said, like, we need to sell depression treatment back to the patients and the providers and the care managers. And so we'd go through this process where they would develop and help us develop these materials. We would send it to an intervention development team of patients and care managers and providers who would improve on these materials, and then an advisory board to make sure that everything that we were creating also had behavior change techniques infused in the materials, that we weren't just going too far ahead, and that we maintained the effectiveness of these interventions. And then we would user test with patients and care managers and providers. And then we repeated this process over and over and over again. So at the system level, for every level. So at the system level, for example, we knew that we needed some local. The state was already providing centralized resources. We needed something local to be delivered by the clinic mental health staff. And so initially we thought maybe we need to focus on cultural adaptation and billing. And over time, as we iteratively improved this, we realized, no, what we really need to do is adapt to the context. We need to change the program a little bit and adapt it so that it fits the needs of the clinic and the program. Next slide. At the patient level, I'm almost embarrassed to show this. We started with a very small little PDF. We thought it would be simple. These are historically marginalized patients. They often don't know how to use technology. But over time, it expanded out into this entire large experience for patients. And so they were very clear. We don't want anything in Epic. We actually don't even want anything. We don't want any technology to provide us treatment. We really wanted, this was supposed to be a connection to a human being. And so this was going to be a web app that would be texted as we iteratively improved it, nothing in Epic. They wanted options to bypass their primary care. There was a concern that, hey, if we, if our doctors know about this, maybe they'll focus less on our physical complaints, and we don't want them to do that. We knew that it would provide psychoeducation, and it went from being shared decision-making, and this is something else that we've been thinking a lot about, is can shared decision-making really improve implementation? It's more that we needed activation for a lot of these more resistant patients in the sustainability phase. And people have different experiences. Maybe you were already on an antidepressant, or you've already done therapy. We can't give you the same tool. You need a completely different message depending on where you've come from, your experience with mental health treatment before. We can't just give everybody a static experience. And as we saw, and these were 43 racial and ethnic minoritized patients, 50% of them were older than 65. We had a blind person, there was some audio that was involved in this. And so over time, you see an increase in usability, and we met the threshold that we needed to kind of go forward in terms of our pilot. Next slide. So this was our study. We took like I said, if at the bottom left, you can see that these are clinics reporting data to the CCMP program. And we took 5 of the worst clinics, the lowest fidelity clinics. And within those clinics, as a pilot, before we, disseminated it out to the rest of the group, these 44 providers were randomized to either getting a system level strategy. So they had access to care managers who were getting that technical assistance, pilots, better communication with providers, iteratively improving and adapting the program. And then the other half of providers got the same system level strategy, but we also added additional behavior activation and success stories and other, just more bothering of the providers. And then a subset of patients in a demonstration project in a group of consented patients got our tool just to see how it worked within our setting. And the good news, we had very high fidelity. Most of the champions attended, at least one champion per clinic attended every single technical assistance meeting that we had during our implementation or sustainability phase. Next slide. So what did we find? So amongst the 1,253 patients eligible and who screened positive for depression during this period, we see that their providers were more likely to optimize, and not in a significant way, treatment for those patients. So they were more likely to titrate an antidepressant, refer them to psychiatry, for example, and make some change for those patients. On the patient side, we see a pre-post improvement in patient optimization. So patients were more likely to attend some kind of new treatment, new psychiatry visit, start a new antidepressant, et cetera, during this period, pre versus post. Next slide. And I'm breaking this up on purpose. And I don't think that there are a lot of multi-component interventions that just tell us what happened, but we don't always break it up to figure out what happened, which component worked best. And so it's possible that this was just a post-COVID bump. It's possible. And so we look to see at the other clinics, the CCMP program. And you can see here that in our depth care clinics, we see this improvement in the percent of patients screened for depression across the population, improvement rates. So this is remission rates for depression of patients in the collaborative care model, contact rate, which is a fidelity metric. Psych consult, if a patient's not improving, does the champion within the collaborative care program touch base with the care managers on this patient, but no improvement in reach of collaborative care, which makes us think that those improvements that we saw were in other things like medication, psychiatry, et cetera. We don't see those improvements in the rest of the state. And maybe this is just regression to the mean, but when we look at other very low fidelity clinics like ours, again, no improvements in their metrics during this period, which makes us think there was something happening locally that led to these improvements. Next slide. When we tried to contextualize these findings, I think the issue with reach is that we still had psychosocially complex patients that were just ineligible for the program. It doesn't mean that the care managers weren't touching patients and coordinating and getting them to a psychiatrist. It just meant that fewer of them were eligible to stay within the program. And then the psychiatrist, who was part of the care manager program, had some turnover. And so that could explain why the psychiatry metrics didn't improve. But our hypothesis is that the adaptability, the redesign, the lowering of PHQ thresholds, all of these different metrics, the trialability, many pilots. We sent a subliminal message around depression screening to improve depression screening rates. All of that stuff probably improved population level optimization rates, and also collaborative care fidelity, which led to improvements when we start thinking about the mechanisms by which this likely happened. Next slide. So what happens when we add? There's some evidence that maybe the system level intervention worked pre-post. Now, again, these providers were randomized. What happens when we added extra stuff to the doctors, bothering them some more? So the red is the system only. So you have care managers who are communicating better with you. You see this improvement in placing at least one referral to collaborative care pre versus post. But the added extra attention, you actually see a reduction in placing at least one referral. And I think this allows us, I think we've been assuming that the problem with mental health is there's just not enough resources. And I think this gives us a little bit of a glimpse that these care managers were wide open. Like I said, they were covering only 30 patients per FTE. They had plenty of space. They wanted more referrals. And so there's something else going on. And I think we can unpack that as we start thinking about this in the literature. It wasn't that there was any difference in acceptability, feasibility, appropriateness. I do think that the added, and as we start thinking about interventions that target PCPs for everything that we do, the added intervention is probably potentiated by the fact that we had very high burnout and insomnia. A lot of PCPs were leaving during this time. And the fact that there's, just the relative priority during a visit is just not high around mental health. And this perception still that there's just not enough resources. The care managers are too busy, despite the fact that we saw these kind of low care manager caseloads during this time. Next slide. So what about our pilot of our tool? And so what you see here is those patients who got our tool versus those patients who did not. You see this increase in patients starting new treatment, antidepressants, therapy, et cetera, not just collaborative care, but we see a threefold improvement in collaborative care enrollment amongst those patients who got this. And it doesn't appear that this was happening through the provider referral. It seems that patients were bypassing the doctors to get in. And so we have some evidence of this with all these messages, or sometimes reaching out, hey, I got this message, doc, can you please send me a referral? And that seemed to work. But it doesn't look like telling the doctor in real time that, hey, we've done everything. The patient's activated, they're educated. All you need to do is put in a referral, still no difference in provider optimization and behavior. We see that those intervention versus control, there's a trend towards improvements in depressive symptoms over time. Those patients had higher trust in their PCPs, higher collaborative care acceptability, fewer perceived barriers to collaborative care. And we see evidence of PCPs maybe normalizing depression and some resistance to ownership. There's one patient who was suicidal, despite all of the messaging to the provider. If you look at their note the next day, they referred the patient for a sleep study, despite the fact that the patient's PHQ was 15. And so for some roadblocks for this, and in our next iteration, we'll be sending this out to everybody in our clinic. Obviously, as part of a demonstration project, we were consenting and cold calling right after COVID, which made it very difficult to get a ton of people. But the plan will be to kind of disseminate this to the rest of the entire clinic after this pilot. Next slide. So some lessons learned. I think that theory-informed system-level strategies that promote adaptation may be sufficient to improve population treatment optimization rates and collaborative care fidelity and outcomes within those patients in collaborative care models, but not enough for collaborative care reach. And there is this thought that well-designed direct-to-consumer approaches, within our tool, it included CBT apps and access to other things that patients could do that we vetted may improve reach of collaborative care. And the thought is to maybe disseminate this regardless of PHQ score and even regardless of treatment, whether or not they're in treatment, patients can always be optimized. I think we need additional research on strategies to promote PCP involvement in the post-COVID world, particularly given PCP burnout. These original models really hinge on PCP involvement, and maybe we need new models. And maybe we need to adapt this in a way that doesn't require so much. And does that change the effectiveness of the models? These are all questions that I think we still need to answer. Similarly, we started as a step wedge design, and I have thoughts on this. In real world settings, this can be very, very difficult. And I think we learned a lot at these marginalized populations about some resistance attack and the wish that this could be a way to connect them to a human being. And then there are some other interesting things about IRBs and implementation science. I think the IRBs still call for a lot of consent when you're doing something in the real world that's otherwise low risk. And these are other kind of considerations that we're thinking about in the field as well. Next slide. Next. Okay, great. So next steps, we're thinking a lot about mechanisms by this work. What are some moderators? What are some of the determinants by which our different levels of our strategy work? This R01 formed the basis of multiple other R01s. We're doing this in cardiac care and using other use cases for PM and telehealth. And so very grateful to ARC for helping me launch this IMSci lab that we have running. And then our next step right now is we're writing a grant on disseminating this out across our network of Medicaid clinics as a sustainability toolkit that would include our tool and more rigorous overviews of that technical assistance that we provided so that it would be easy to package and disseminate to other clinics as well. And that's it. Thank you so much.
Thank you, Dr. Moyes. That's another interesting presentation. And if anyone in the audience thought the implementation was a piece of cake, you've learned otherwise today. So we're going to go next to a discussion about the ARC Academy. And this is going to be a joint venture between me and my good friend, Dr. Neil Corson from the Maine Health Institute for Research. Next slide, please. The Academy, in brief, is a national resource for the integration of behavioral health in primary care, which includes mental health and substance use disorders. ARC provided funding for this in 2010 and has continued that since. The directions and the activities are guided from a national expert panel, of which Dr. Corson is the incoming chair. He's headed for that role. And what we try to do is gather and disseminate relevant literature and useful tools. Next slide. Everything that the Academy does is available on the ARC website at this URL, integrationacademy.arc.gov. And that's where you go to get all our resources. If you just go into Google and type Integration Academy, it'll pop right up. At least it does in my browser, perhaps from practice. But next slide. Brief historical background. We've been talking about the need for integrated physical and behavioral health care at least since the 1970s. For me, and I think many others, broader awareness came with the President's New Freedom Commission in the early 2000s. The final report and particularly the issue paper by Dr. Jürgen Unitzer drew real attention to the interface of behavioral health and primary care and the approach of collaborative care and primary care behavioral health. ARC awarded a grant to Dr. C.J. Peak, an amazing human being. It has been a delight to work with over the years to develop a common definition, because everybody was talking about integrated care, but they all use different terminology and it seemed to mean different things to them. And that resulted in the Lexicon for Behavioral Health and Primary Care Integration, developed by Expert Consensus, that was published in 2013, and we have just updated that in 2023. And with that, I'm going to turn it over to Dr. Corson and the next slide.
Thank you, Garrett, and I hope and expect that you will feel free to kibitz in, because you're going to have things to say to complement what I have to say, no doubt. So good, I think morning and afternoon, depending on where you are in the country. Just a little background on me. I'm a family doctor. I practiced in rural Maine for about 20 years. Decided I wanted to be a researcher when I grew up, and the research I've gotten to do has a lot to do with behavioral health and primary care. So the lexicon definition, as we worked on this, and there was input from people with lived experience as well as from people who've been working on integration. And we decided to use a very broad definition, as you can see, in particular as we thought about the application of integration to healthcare, that while I believe some of the thinking about better integration started with the challenges in addressing mental health and substance use conditions in primary care and the value of having resources to help us do that, it's very clear as you work with behavioral health clinicians as members of your team that there's lots of other things they can help us do in primary care, and we really wanted the lexicon definition to reflect that, and I think it does. The other thing I discovered as I Googled definition of integrated behavioral health, this is the one that comes up first and most often, and has influenced a lot of other definitions that other groups are using. Next slide, please. So I'm going to spend some time going over some of the other resources that have been developed for the Academy website. It's going to be high level, and part of my goal is to inspire you to take a closer look and to browse around the website and see all the excellent resources that we have. Next slide, please. We're going to start with I'm going to start with the literature collection. So this is both focused and broad. It's focused in the sense that it's all about behavioral health integration. So rather than searching Medline, which has millions of resources, this is a collection that allows you in a much more efficient way to find the resources related to behavioral health integration. And it is broader because we purposely included gray literature, by which we mean reports, workshop proceedings, other resources that, while they're not in the peer-reviewed literature and therefore not accessible through Medline, they are important sources of information about integration. And the literature collection has links at least to abstracts and often to the full text of the resources that are being described. Next slide, please. Topic briefs are a relatively new type of resource that we have on the website, and the topic briefs were developed, as you can see, to provide timely information in a succinct format. And it's a way that we can address new and emerging issues related to integration. This is one, Garrett, where I don't know if you have any more that you want to say about how topics are selected, but you can see from the list of topics that these are things that we wouldn't have been thinking about in, let's say, some of these in 2018. So really emerging topics. So anything to add, Garrett?
No, and in interest of time, let's keep chugging along.
Okay. If somebody asks us a question, we'll answer it.
Yes.
Another set of tools on the next slide are, next slide, please, are the sets of tools for alcohol use, specifically and substance use generally, that have been collected. Again, these are databases of various tools and resources that are both searchable and filterable. Next slide, please. These are our implementation tools in particular, the two playbooks that have been developed. First, the integration playbook, which was general guidance about how to integrate behavioral health in primary care. And then the MAT playbook, which is actually going to be revised and will be renamed the MOUD, the MOOD playbook, looking at medication for opioid use disorder. Both of those are really step-by-step guides about how to implement, targeting practices, but also large organizations that might have multiple practices. Each has a self-assessment guide, so you start by assessing where you are. You can use it in a sequential way. You can use it to just address particular aspects of implementation that you're working on. There's advice about implementation, sustainability, resources, and one of the things that we thought would be really useful for when we first started the integration playbook is a list of what not to do. So the people involved in developing the playbooks had worked on integration. We had learned some lessons. We didn't want people to make the same old mistakes that we made. We thought it would be more useful to make new and interesting mistakes. So the what not to do guide hopefully kept people from at least going down the paths that we went down without success. Next, and at least last slide for this presentation, are a couple of useful and interesting resources. The study of exemplary practices was something we did relatively early in the days of developing the Academy, and we were able to identify high-performing integrated practices around the country, and we then studied them. We did on-site direct observation as well as review of materials. It was a very interesting study to understand how they did what they did and what we could learn from them. And so the lessons have been written up into a guidebook. The second resource that I'm talking about here is a literature review that was initially designed to look at competencies for clinical staff involved in behavioral health integration. And as the literature review was done, it was recognized that there were also resources on practice level competencies. So the review is both individual and practice level information to help people who are working on integration. These are a couple of other resources that are really good to support the implementation process. So that is just an overview at a high level of what the Academy website has to offer.
Thank you, Neil. And this is, yeah, there's so much on the Academy, and I really hope that you all will take the time to go and take a good look at it. We have just about 6 minutes left. We want to get some audience questions in here. Just as a reminder, you can go to use the chat feature to submit your questions. And I don't know whether we have some that have come up already. Oh, we have, oh, that's right. We have more time. Good, good. So while Diane is seeing what else has come up in the chat, let me start with a couple. Let me throw one to Dr. Graham. It's clear that you anticipated implementation challenges with the introduction of the digital tools and that you encountered several of them in practice and try to figure out ways around them. What do you think are some of the most important implications for others who would like to implement? And I'll say this as somebody who I was formerly the Associate Director for Services and Policy Innovation at the Rockefeller Neuroscience Institute at West Virginia University, and I tried to do this too. So what you were saying sounded really familiar to me as some of the kinds of challenges. But
and this is where we'll have our future coffee chat together to talk
yes,
more.
yes.
Thank you for the question. And one of the things I love about what you shared at the end in the discussion is the idea that I'm blanking on which year, but it was in the 80s that this original paper came out, or 90s, and it's now, it's now part and parcel. And I sort of hope we get there faster with digital, but so you're catching me on a week where we had some even more things blow up in a positive way, learnings. So I think the lesson our team is really feeling is the importance of having everyone in the room at the same time. So that is a very key component of implementation science. And I didn't share, and please forgive me to the audience, this was actually a unique grant situation where I actually became the PI when my colleague, who was the original PI of the trial, admittedly took a role outside of academia. So to be walking into a trial midway is always an interesting thing, although it gave me some really unique perspectives. But I definitely want to honor the amazing work Emily Laddie did in getting this grant and conceptualizing it and really launching the collaboration with ambulatory care. The reason I say all that is in terms of getting everyone in the room, I think a lot of that had happened before my time, and then time goes on, and then I came on board and we were moving through the field tests, and we talk to people a lot, but not always literally all together. And in consequence, some things can come up where you think one group's all on the same page and they're not. And that was one of the interesting things from this past week, where the medical center's compliance office was having concerns about the role of a digital tool in the healthcare setting from outside entities and how we navigate some of those compliance related things. So altogether, there's several important, fascinating components, because at the end of the day, technology has to keep the lights on. And I did see that there's a question in the chat about who's paying for all this. And that's part of the sustainability model of demonstrating some of this as data to see, like, is this sustainable, supportable, and but that yes, there would need to be a contract longer term with companies to keep the lights on for digital. It's what makes them different from other psychological services to happen. Face-to-face psychological services, I should say.
Chat is about the EMR link for IntelliCare care, and can you talk a little bit more about how that worked?
We originally thought that we would integrate all together into the EMR, and that was one of the other changes that would make doing coaching very challenging, because it needed to be an outside portal due to technological and regulatory issues. And that's another really important constraint, is the ability for different outside entities to integrate, which is very understandable, but something we have to, as a field, overcome. And then I say that because so now what we're doing is the link itself to open the partner portal will be part of the typical clinical workflow, but then it would be open in an external window. And as silly as that sounds, like, sort of the key when we think about behavioral economics and how do we think about behavior change, how do we make it easy on the care coordinator to facilitate a referral? And also on the patient, how do we ease burden on both of those parties? So anything that we could do so that people didn't have to remember to go to outside portals altogether, even if it needed to be an outside portal, is there a way that within the progress note, which is exactly what we did, is we built within the EHR ways to link to that so that it puts less burden on care coordinators to remember, because as humans, what did I even eat for lunch 2 hours ago, right? So it's really important.
Yeah. So sorry to keep asking you questions, but I'm going through the chat, and you were first, so you're so the first questions are all for you. But someone asked if the patients were receiving active counseling or other interventions while they were utilizing the digital mental health.
Great question. The answer is they absolutely can. So this is one offering amongst others, and we're going to track that and see what else they do by using EHR data that is already being tracked. We're going to look at medications they might be getting, and importantly, I think one of the innovations we're excited about is also seeing the impact this has not just on their mental health management, but any other chronic health problems that they may be managing for why they're coming to ambulatory care in the first place. I think that's a really powerful opportunity here. But to the question about, can they do other things? To me, the answer is yes, but the innovation is, are they actually? Because we know that wait lists for psychotherapy are really long. Post-COVID, we have a complete rise in mental health needs, as purpose of this webinar. So I just say all that because, sort of the role that digital can play is an exciting opportunity, but how we make that happen is not a simple task, hence the project.
Okay. So another question is, is about the care management supported by your app. And is that limited to clinical issues, physical and behavioral health, or is it more holistic and wraparound, including social drivers, health-related social needs?
Terrific question. And I just mentioned, keep in mind that the app is sort of the sub any entity here. IntelliCare Plus happens to be primarily focused on depression and anxiety, with med management components added in, and I think a room to expand and sort of vision to expand more of those social drivers as well, and that the coaching can focus more on you as a human being without extending into psychotherapy. So we're very clear about the balance of that, but that people are people and they have stressors going on. And part of the value of understanding what's happening in their lives is helping them link those then skills that they're learning in the app back to how they can manage stressful situations in their day-to-day lives. Always room for optimization in those things.
Right. Great. I think the next question is for Dr. Moyes. Are you able to discuss the nuances of the collaborative care model and FQHCs with regard to sustainability and implementation?
Yeah, I think that some of the issues I think are reimbursement. So I think states are increasingly, so we're lucky in New York State that we have this, and this is why I think one of the reasons that if you look at the differences between the clinics across New York State in terms of reach that participated in this program versus not, 80% of FQHCs participated in this program because there's really no other way to reimburse for collaborative care, unfortunately, via Medicaid. So I think that's a key piece, and which is why states have to be involved. The other thing that I think is really salient is that we found that those clinics that were no longer participating in the technical assistance, it's almost like having Big Brother and having to report data of how you're doing to Big Brother, which is OMH, actually led to better outcomes at the patient level, right? So without that, for those clinics who left the program, who are like, we don't want the free money or the reimbursement, et cetera, we actually see a decay in the quality of care that they're providing. And so that forces us to ask, is it better to provide nothing than to provide bad care? I don't know. Sometimes I wonder in terms of just the quality concerns that we usually see. How do we maintain high fidelity? How do we maintain high quality? And sometimes, you either need Big Brother or an administrator who's monitoring the fidelity, monitoring outcomes, I think, to ensure that you're continuing to provide high quality to these kind of historically marginalized populations. Because then we're just using resources in a place where we could otherwise be funneling them somewhere else. And then I think the other piece about sustainability is that these types of programs, if you think about reimbursement, you need a certain caseload to pay for yourself and maybe even make a profit. And so I think clinics are not always thinking about that, of thinking about the caseload is so tied to reimbursement and paying for yourself, which might be even more important in FQHCs.
Yeah. Yeah, as I'm a big fan of measurement-based care, and I often say what you measure is what you get. You stop measuring, what you get doesn't sustain real well, does it? But,
No, great.
another question for you. In any tools or interventions identified for limited English-speaking patients, what efforts were made to engage communities of color in non-English efforts?
Yeah. So all of the patients that we engage in our user-centered design were from historically marginalized populations. We had our last piece where the usability actually got even higher was all Spanish-speaking patients. And so there was an effort, this tool was in Spanish and English. And then we really looked, when we looked at vetted CBT apps that, maybe you're a very savvy person and you don't want to talk to anyone and you just wanted access to some kind of CBT app and you're very motivated. We made an effort to find those that were free and that were in a different language so that we can ensure that these historically marginalized populations, so that this is not, I do think that I see all of these behavioral health interventions and digital health interventions, and we know that it's better if a coach or if somebody involved, but I still see that these patients desperately still want to talk to someone, a human being, for their therapy in terms of the historically marginalized populations. Can we use these platforms as just a conduit instead of the actual treatment? And maybe think about, ways in which you can kind of siphon or individualize based on what patients want and their preferences. We're also thinking about using AI. Some of the reasons we consented our initial group of 2,000 patients was so that we can start creating algorithms for figuring out who's the best patient for collaborative care versus somewhere else, instead of relying on PHQs, which I increasingly don't really now that I've seen, especially through this project, the quality of the PHQs can really, really plummet in the sustainability phase. You can't even you can't even rely on your PHQs to be a conduit for referring patients because you don't even know if they're real, to tell you the truth.
Nothing's ever easy. Now there's a question, I guess, is for Neil and me on the Academy. And Jennifer McCarthy says, I used the organizational self-assessment with a rural health center and found it very user-friendly. That's great. I'm not sure whether that was for the MAT playbook or the integrated care, but thank you. I'm glad it worked well for you. So now I'm looking to see if there's questions here that I have missed. I think, Diane, I think that pretty well covers questions that have been submitted so far, unless there's some way down here. Scrolling this and trying to read it in real time is challenging. But we did have some other questions that we were thinking about. I guess back to Dr. Graham, thought leaders have identified billing and payment as one of the major challenges for implementing behavioral health apps. And we know that systems aren't in place to cover that everywhere. Some states, some managed care organizations are doing it, others aren't. I guess you used grant funding for this, but what is the status that you all are seeing as a group trying to implement behavioral health apps, and what are you looking for in terms of change going forward?
They can't all be free everywhere all the time. Yeah, exactly. It's almost like, do I have to answer this? No, I'm just joking.
Especially when coaching is included in the cost of the app.
That's exactly
That's
right.
personnel. Yeah.
Yep.
Mm-hmm.
So the answer to that is I don't have a strong answer, but the people are really passionately working on this. So within our center, the center director, David Moore, has founded the Society for Digital Mental Health, where there's a sub component of that society. One of the main goals of the society is to be thinking about sustainable implementation, including cost structures to support this and billing codes and things of that nature. And within the society, there's a implementation work group. I'm part of that, where we are meeting. There's leaders from across sectors really trying to bring to bear learnings and understandings, and then sort of how do we move forward policy changes to really support this. It's a fabulous question. I wish I had more. I'll just say more people know, smarter people than me know some of those real nuances, and but it's absolutely important that we learn to solve this.
Yeah. Through my discussions with ARC, I am aware that this is an issue that the feds and through various organizations are aware of, and there are efforts at least in the current administration to change that, and we'll have to see what happens in the future.
Mm-hmm.
So, and back to Dr. Moyes, if I understand correctly, you first tried a shared decision-making approach, and then you switched to direct-to-patient, patient activation. Can you say a little bit more about the approach to patient activation and how you did that?
I think it's
what you might recommend to others?
Yeah, I think this has been so interesting. We're part of another ARC has a shared decision-making group as well, having such interesting conversations about equipoise and when is shared decision-making, is shared decision-making the thing that we're supposed to be implementing, or is it an implementation strategy? And what you find is if you just talk to someone about their option, it doesn't mean that they're actually going to utilize something. It doesn't mean that you're going to implement something just via shared decision-making. It's often that they need a little bit more behavioral activation, a little bit more activation in terms of motivational interviewing. So we did things like, it's almost very similar to motivational interviewing, where you get a sense of first how interested they are already. If they're not interested, why is that? What are some barriers? You go through, and the tool actually took them through, hey, I thought, I think I have to pay for a care manager. And it's like, actually, care management is free in our clinic, right? And so you go through all of these different components of taking them through barriers, why they're not interested, and then re-asking the question in different ways, or getting them to think through What are some of the things holding you back from being interested in collaborative care or interested in an antidepressant or a medication? What if you knew certain symptoms, and then the tool referenced the symptoms that were bothering them the most in terms of their PHQ? What if you knew that this could help these specific symptoms? So it takes them through to some extent, and it's a little bit more activating then. And it also has some shared decision making. So shared decision making requires that you educate the person, you go through their options, right? And so some of that is also infused. What we realized as we were iteratively, so the nice part about this is that sometimes when you're using user-centered design, you're just designing for usability. And we were designing both for usability and effectiveness. We would say, oh, if we don't add the activation, we're not going to see as many people interested in treatment by the end, or a reduction in barriers. And so we had to, as we iterated, add some of the activation language for those patients. And it's very easy to do. It doesn't take very long to do this tool. We tested this in third grade or third grade reading level or second grade even in Spanish, again, translated and then brought it back to reduce the literacy in Spanish. And so we tried very, very hard to make this something that people could just open up and use without ever having, without any experience with technology necessarily. And this pivoted from being in the waiting room too. We were thinking this would be in the waiting room to knowing that, hey, post-COVID, we can't really do a lot in the waiting room. It's going to have to be something in their own phones. And I think that actually helped a lot because it was something they were comfortable with instead of giving them a new technology like an iPad, which was the plan. And so in some ways, I think it became a better tool afterwards.
So building on that same question, the new question here is, can you describe the tool or intervention that was used in DEP care? So we saw that picture up on the screen, but
yes, that big
open that box a little bit.
Yeah, so we knew that we couldn't always trust the PHQs within the system because I'd seen evidence of some decay in quality. And so the tool takes you through the PHQ in a little bit of a lower literacy way to take you through one page at a time. So you're screened. And then we had something new of like, most patients were like, nobody has ever explained to me what my score means. What does that even mean? What, there was that taking them to the inside of what goes through somebody's head when they decide to get into treatment. And this was just based on a lot of our discussions with historically marginalized populations. Like, first you have to have the insight that I have a problem. And how do you guys know I have a problem, right? And so it does take them through what your score means, what your phenotype is. You almost get a phenotype. You're the anxious, depressed phenotype and what that means and what it looks like and some of the other symptoms you might be experiencing. Like one of our patient stakeholders said, you guys talk a lot about suicidality. She's like, I feel homicidal sometimes. Like I feel angry. Nobody talks about anger as a depressive symptom. So we're talking about some of the traditional symptoms as well. So people could start being like, aha. And then we actually did a casting call for people with lived depression who were historically marginalized populations, and they sent us their stories. And that's how that was part of the psychoeducation. And we had the patients choose which one like really got you, and everybody picked the same one. They're like, that one really, even when I see it, I cry a little. Every time I see that video, I don't know how she did it. So it has all of these things that takes you through the emotions of re-experiencing the depression. You're going through all these things. Somebody else like me experienced this. They also tried non-traditional things like going to church and prayer and all, medications, and it still didn't work. And it doesn't have to do with where you came from or what happened or your experience. They might just be like, well, I'm just depressed because I lost my job. And so you have to go through those experiences. And then there is a physician that comes up that goes through, or a care manager that's basically a marketing. We have the care manager program here. We can help you. And so it goes through a lot of different pieces. And then I talked a little bit about the barriers for those people who are like, no, I don't want this. It takes them through a little bit more of the activation of like, it's okay if you don't want to. You can still end with saying, I don't want treatment.
Right.
But they've now walked away with not only this, but at the end, I think you could see the flow. There are all of these pictures, so you can walk away with something tailored for you. So if you're already in treatment, maybe you just need to be able to go to your therapist and try a different type of therapy, like CBT if you've been doing problem solving, or so how do I talk to a therapist about trying a new type of therapy? And so those patients got a different experience than those people who are kind of brand new to the experience.
Yeah. Great, thank you. This one I think is for probably Matt Simpson. are there any funding opportunities for doctoral students through the Academy? And they wouldn't be through the Academy, but ARC may have some things there. So
Thanks, Garrett, and always excited to have more funding applications come in for ARC around integration of behavioral health into primary care. As you mentioned, the Academy does not issue funding announcements in and of itself, but that would just come from our agency overall. And I can put a link into our active funding announcements. As of right now, we don't have anything that is a specific one related to integration of behavioral health, but it is a key issue, and you can always look at other parts of our pages to identify how to, map it to an ARC priority. So looking at special emphasis notices, for example, or within our effective healthcare program, we have systematic reviews that will identify key evidence gaps. And if you can cite one of those in an application, that can also help out. And so look at our funding announcement page, and if you have any questions, reach out to myself, reach out to a program officer listed on the funding announcement, and we can kind of help guide you through the application process.
Great, thank you. Diana, I'm not sure exactly how much time we have left here. There is a question that I'll just sort of open up to any of the panelists. How can value-based care impact these interventions, since cost is one of the barriers? Anybody have brilliant thoughts that they'd like to
I
throw
think
in?
that like our the OMH program that we were basing this on had a value-based component, right? So you could, if for every patient you're enrolled, you got 75% of the cost, an additional 25% if you could show improvement of that patient. And nobody asked for that extra 25%. And it wasn't because they weren't showing improvement, it was just too hard to collect. And so I think as policymakers are thinking about, reimbursement infrastructures, just saying that we're going to do value-based reimbursement, I still think that you need to think very carefully about how difficult it is to collect, what that measure is, how important it is for us, right, to some extent. And so I think it's been very interesting because we can't just do any value-based components are not going to work here in terms of improving the uptake of these collaborative care models.
Right. And well, there is payment now for collaborative care in most places, not everywhere, but most insurers cover it, and Medicaid and Medicare everywhere, and Medicaid in most states covers it. So, but the apps are a different story, where just the payment mechanisms don't exist as yet. And somebody else has a question about AI and chatbots, and I will say that I'm not aware of anybody who has combined the behavioral health app with AI features as yet. That may be something that comes in the future, and of course we all know that there's great opportunities and great risks associated with that. So I think that's a thing that will roll out in the months and years ahead, rather than something that's a current reality.
We'll need to wrap up the webinar.
Okay. All right. Well, thank you all for the great discussion, very interesting presentations, and I've enjoyed this. I hope you found it useful as well. And please come visit the Academy website. Take care now.